So my topic is recent updates in diagnosis and management of fungal infection. First of all, dermatophytosis is the most common superficial mycosis with Indian prevalence of about 27-28%. And not exaggerating, but as much as 30 to 40% of my OPD is studied with superficial fungal infection for last about 3-4 years. So the prevalence is increased to as much as tenfold if I compare the scenario before about 5 to 6 years. In India, it has been a common infection that was easily amenable to the treatment with topical and sometimes systemic antifungals. But however, in past few years, it has been seen that a tremendous increase in number of patients with recalcitrant dermatophytosis is there. So the problem is widespread use of combinations containing antifungal steroids, super potent corticosteroids prescribed, antibiotics unnecessarily, either by self-medication or prescription by misinformed persons. So this is how the fungus goes inside the skin. It produces keratinase, right? The keratinase digests keratin and it goes inside the skin. Fortunately, it only produces keratinase that doesn't pass through the skin layer. If in future days to come, it will produce more enzymes and there is a penetration beyond the skin, beyond the vasculature, beyond the viscera, then it would be a havoc. There is extensive morbidity and mortality. For last 5 to 6 years, it has been increased by 10%. Now, what are the reasons, suspected reasons, why the scenario is changing like this? First, patient's factors, if we see steroid and irrational combinations, because steroids decrease the local immunity substantially, not looking for involvement of hidden sites, overcrowding, ping pong effect, the other family members are suffering from the thing, changes in the fashion sense, lot of use of jeans and tight clothings. These are the patient's factor responsible for resistance. Now treatment factors, non-compliance. The major factor is non-compliance with the treatment. Poor penetration of topical treatments, bioavailability of previous use of inadequate treatments, inadequate dosing and duration, polypharmacy, and other comorbid conditions like diabetes and immunosuppressive conditions. Now, superficial infection, if we broadly classify, there are three groups: dermatophytes, candida, and malassezia. Out of all, dermatophytes are most common. And among the dermatophytes also, trichophyton rubrum and T. mentogrophytes. These are the two organisms. Why I'm going in detail? Because most of the studies are conducted upon T. rubrum species. Whether the drugs are there, whether the bioavailability, whether Cmax or Tmax is concerned, they are most commonly conducted on T. rubrum. But now with a changing scenario, T. mentogrophyte is taking over T. rubrum. So the previously available drugs, previously useful drugs, they are not getting effective in many of the patients just because of changing scenario of pathogens. Other are Candida, Malassezia, and molds. Candida albicans is most common, and M. furfur is commonly responsible for Tinea versicolor. Gujarati में करोड़िया जे कहिए, that is Tinea versicolor. Now in recent years, there seems to be an epidemiological transformation of dermatophytes. Studies done across the India said that it is T. mentogrophyte which is more commonly prevalent rather than T. rubrum. And in an interesting study, it has been studied that T. rubrum survived for less than 12 weeks in a towel, and the T. mentogrophyte species is able to survive for more than 25 weeks. So it is more than double survival rate. So this is significant. As you can see the graph, previously there was a low prevalence of T. mentogrophyte, and now in 2016 studies conducted, it is more than six-fold rise, right? So this is the commonest cause of drug resistance. These are the cases nowadays we come across in our OPD. Previously, one or two patches here and there, mostly in the groin region or wet areas. Now it is extensive, even more than that. This is, say, less than 50%. Even more than say 40% body surface area involvement cases are not uncommon in OPDs. So large size lesions are there. Now more than common to see this kind of patient. Tinea cruris and corporis are more common. Now this is a fungal cell wall culture, and ergosterol is the main thing. Fungus cannot survive without ergosterol. So the drugs which are targeting this ergosterol are more effective nowadays. Now what should an antifungal, ideal antifungal should have? It should have a broad spectrum of activity, potent antifungal activity. Rather than fungi static, it should have fungicidal activity, highly effective against T. mentacophytes, long reaction time, long retention time, high mycological and clinical cure, lack of development of resistance, and a safe and well tolerability. These are the things which are looking for. We are looking for an ideal antifungal. Now, how to manage? We generally the diagnosis is very easy. We see the case and we come to know that it is a fungal infection. Now, what is the management? This is a tricky condition. Previously, we used to see the cases. I'm talking about 2010 in our residency, after residency, and we give Itraconazole 100 milligram OD for 10 or 15 days, and there is complete cure. Now, it is not the scenario. Within just 10 years of duration down the line, the fungus is resistant to such an extent that 100 milligram BD for even 2 months, 3 months of duration cannot give you a proper cure. So this is the worrisome condition. So proper diagnosis is very important. Inappropriate topical drug like steroid combination should not be used. Appropriate systemic drug should be used. Proper drug dose and method of application, proper duration of the treatment, combination of therapy where it is needed, family screening to avoid ping pong effect, screen for the factors compromising immunity, and stress on compliance. These are the things which is very important. Diagnosis, as I said, is very simple. Some KOH smears are available, so we can take a scrap and send for KOH smear. Sometimes in few selected cases, even fungal culture we advise. Otherwise, most of the time it is clinical. So these are the few things. Control comorbidities, personal hygiene, washing clothes and linen properly. This seems to be very, very unimportant, right? Clothing the clothes, what is that? But the fomite infection is very common. From a mother, fungal infection, it can transmit to a child, from a child to his father. So the fomite is cloth. Many of the companies have come up with antifungal wash, cloth wash nowadays. So it is very important to control the chain, right? So in this this fomite cloth is very important. Avoid sharing of clothes, cleaning, and avoid systemic, synthetic and tight clothing, which is very important. General measures guideline how to treat. The choice of antifungal depending on pharmacological properties, history of prior exposure to the drug, the site and extent of the lesion, and skin area involved. What skin area is involved? Suppose a larger area is involved, the choice is different. Suppose a hairy area is different involved, the choice is different. Nave and recalcitrant tinea pedis causes to be treated empirically with a combination of topical antifungal systemic drugs. Right, tinea cruris and corporis localized lesion to be treated with topical antifungal alone. For extensive and recalcitrant lesion, we can take help of antifungal systemically. Topical drugs should exert anti-inflammatory, antibacterial, and broad-spectrum antimycotic activity. Preferred systemic agents should be chosen carefully, like itraconazole or terbinafine, or even sometimes fluconazole is effective. A higher dose of systemic antifungals can be considered in few cases only, including deep inflammation, multi-site involvement, and non-responding cases. A minimum duration of treatment should be 2 to 4 weeks minimum. It can extend even more than 4 to 8 weeks. Abrupt withdrawal of topical corticosteroid should be practiced in tinea incognito, where it is difficult to identify kind of stuff. Topical corticosteroid use in clinical practice of tinea management is strongly discouraged. Adjuvant therapies like antihistaminic, sometimes we combine the antifungal topical with salicylic acid. to enhance the activity, enhance the coverage. Baseline LFTs and a periodic monitoring should be considered. An empiric therapy of choice in pediatric age group is topical antifungal alone, but sometimes you have to take help of systemic agents like fluconazole, terbinafine, or very rarely itraconazole. As we said, these are the four pillars of antifungal systemic therapy: itraconazole, terbinafine, griseofulvin, and fluconazole. Out of these four, terbinafine, griseofulvin, and fluconazole are getting more and more resistant. They are effective, but in couple of cases only out of 10. Otherwise, they are getting more and more resistant. Even in last couple of months, we have seen cases of even itraconazole resistance. Now the dosage is very important. Itraconazole 3 to 5 milligram per kg. Terbinafine is 10 to 20 milligram. 20 for 10 to 20 kg it is 62.5 milligram, and in adult weighing more than 40 is 250. But we come across patients who are weighing more than 70, weighing more than 90. There the dose of 250 milligram is insufficient. So we can combine, we can double the dose 250 BD, right? Griseofulvin not widely used, not widely available also. I know 2 or 3 companies who produce it, but it is a useful drug. And fluconazole in maintenance dose, yes, we do use. Few interaction, few adverse effects are there. Otherwise, they are pretty safe. Now, they have come up with few super bioavailable drugs. With the help of 50 milligram, we can achieve the concentration in blood as good as 100 milligram. So, what are the advantages? Super bioavailable, available itraconazole. No requirement of acidic environment. Previously, we used to taught that should be taken with a glass of cola and all. It's so impractical. So SB preparation cannot be, it should not be dependent on the acidic environment. Bioavailability is improved. No interaction with food. No interaction with gastric acid, and less intra and inter subject variability. So in general, it has got improved clinical efficacy. But US FDA approved only 65 milligram SB preparation, no 50 milligram. So I think we should use 50 milligram SB preparation, 65 instead of 50. Special scenario. Yeah, some fungal infections are there. Their patients are pregnant or lactating mother, even kids. So pregnancy and lactation topical antifungal should be the choice of drug. But sometimes, if at all indicated, during pregnancy, terbinafine can be used, and during lactation, fluconazole can be used. Though itraconazole is not recommended during these two special conditions. Infants and children, as I said, topical is the choice of drug, but sometimes fluconazole is safe during the childhood phase, can be used. Elderly persons in those systemic disorders, better to be more precise for topical only, but sometimes itraconazole can be done. Now somebody has got liver ailment, somebody has got kidney, then what to do, right? So there are few rough guidelines, though we can juggle upon. But fluconazole is recommended as a relative safe options in hepatic dysfunction with strict monitoring of LFTs. Itraconazole is comparatively a safer option with renal dysfunction, and in patients with cardiac illness, terbinafine is preferred. These are the rough guidelines. Otherwise, we can monitor the thing and we can juggle upon. Adherence to the topical therapy is very important. It is a key to fight the antifungal treatment. Strategies for improving adherence: identify the poor adherent people, ask about the barrier, emphasize on the value of regimen. Sometimes the costly treatment patient cannot afford. So the value of the regimen should be very important. Provide simpler and clear instructions, and obtain help from the family member. These are the steps we can obtain. Now we know what is the fungal infection. We know how to diagnose, but these are the things which are commonly misdiagnosed. This is not fungal infection. Any sort of localized lesion, any sort of well demarcated lesion, any sort of round lesion is not fungus. Right? First of the thing here, it is a lesion of psoriasis. Second is polymorphic light eruption, and this is lichen planus. These are different these are different from fungal infection. Here there is no need of antifungal treatment. This is very important to preserve itraconazole for the future days to come. Right? This is not a fungal infection. No role of antifungal treatment here. This is not fungal infection either. First is atopic dermatitis, kind of eczema. Second is contact dermatitis. It's a kind of dermatitis eczema. No role of antifungal, neither topical nor systemic. This is again very commonly diagnosed as fungal infection. This is pityriasis alba on the face of a child. No use of antifungal at all. This is a kind of eczema. A mild moisturizer and a mild topical steroid will give the result. As I said, clotrimazole combination tubes are available freely in the Indian market. This is a pity of Indian pharmacopoeia. These kind of combination hasn't role in any of the dermatological disorder. 4 drugs, 5 drugs, clobetasol combinations, and this is a major cause to provide fungal resistance. Antifungal therapy is not effective because it gradually provides this kind of lesion. This is called atrophy. These are not book pictures. We generally come across these kind of cases frequently. Even ulcerations, right? People are applying clobetasol combination like anything, and they can end up in this kind of stuff, and these are not reversible. This is permanent. So this is because of clotrimazole, clobetasol, sorry. Now, few important things about itraconazole. It has been widely used nowadays. What few things should be taken into consideration? Drug interaction. The drugs decreases itraconazole concentration, like isoniazid, rifampicin, rifabutin, carbamazepine, phenytoin, phenobarbital, efavirenz, and nevirapine. This has got some interaction with itraconazole, should be avoided. Drugs contraindicated with itraconazole, again rifabutin, carbamazepine, astimizole, right, are good alkaloids for migraine and for anti-neoplastic treatment, midazolam and triazolam, like phalodipine, right? These are the drugs should be avoided if we are giving itraconazole, or if we are at all giving this, avoid itraconazole. Common itraconazole drug reactions or common adverse reactions are headache, nausea, vomiting, diarrhea, urticaria, and skin rash. Though sometimes we can see hepatic toxicities, upper respiratory tract infection, sinusitis, even leukopenia, visual disturbances, tinnitus, dyspnea, pancreatitis, etc. So what is the ray of hope then? Right, itraconazole is getting resistant. Rest of the 3 are already resistant. Now, few ray of hope is triazole new combinations like posaconazole, voriconazole, revuconazole. Yeah, these are the available drugs. Maybe in future days to come in India, it would be available. Allylamines, echinocandins, and amphotericin B variants. These are the ray of hope.
2 minutes left, sir.
I will be able to complete. Thank you. Amphotericin B, widely used in mucormycosis. This is a antifungal for resistant cases. Lipid formulations, you must be aware about the advantages and disadvantages. Fluocytosins, these are the newer drugs in pipeline. In future days to come, we'll be able to use it. Voriconazole is available, but it is too costly and the dose is not convenient enough. So we are not using it frequently. Capsofungins, candid, right? This is called penicillin for fungus. Penicillin for bacteria is so effective, so it is called penicillin for fungi. Posaconazole again is a drug of choice for resistant cases. So to summarize, accurate clinical diagnosis in superficial fungal infection is the key step. However, timely treatment is also important in dermatophyte infection. Treatment approaches include both topical and oral antifungal in combination. Prolonged treatment duration and poor compliance are the major factor. The most effective way to combat these infections may be to educate patients, and on preventive measures, and a good adequate counseling can change the outcome. Thank you.
Thank you very much, sir.
Thank you.